Welcome back to the Physio Matters podcast, this month in association with Rehab My Patient. This is session 98. Hello, welcome back to the Physio Matters podcast. Jack March here to introduce this episode, and boy am I excited about this one, but I'm excited for other reasons as well. So not only are we at session 98 with a brilliant recording with Claire Robertson all about the knee and the patella, which covers so much ground, super applicable to practice, really brilliant, as Jack introduces it, similar in some ways to the Joe Gibson podcast we did, which was very, very popular. And I expect this one to blow the popularity out of the water as well. Claire is brilliant and the explanations are sensational. But I'm also excited for other reasons. Not only are we very, very close to our 100th episode, that'll be 100 months in a row without missing a single Physio Matters podcast. We're going to make some changes. We're going to bring some innovations. Episode 100, it's going to be amazing on its own. Watch out for the notifications about that because, well, let's just say we've gone mad, basically. Completely mad. So look out for that. But also, we have now released through Physio Matters a knee bundle. It's knee month here at Physio Matters HQ, and the knee bundle contains loads of recordings from our Therapy Live conferences and other CPD productions, including presentations from Claire, all about the knee, loads of different topics covering everything that you need to know to become an absolutely brilliant clinician on the knee. So it includes 10 webinars and basically 10 hours of content for you to get through, and for an absolute bargain price. There will be a link to buy that below, whichever if you're watching this on YouTube or listening across the audio channels, find the link below and you'll be able to go there and have a look at that bundle. We have other bundles as well and more on the way, or of course you can be a premium member, which is by far the most cost-effective way of doing it. Just head to physio-matters.com and check out what we've got available there. I'm not going to take up any more time. We're going to get straight into this amazing podcast with Claire. I'll be back at the end just for a quick roundup, and I'll see you then.
Glad to be here today with Claire Robertson to discuss her favourite topic, I think it's fair to say, which is all things associated to the kneecap, patellofemoral pain, plus or minus syndrome, depending on what team you're on. But I can't think of anyone better to explore this conversation with. We're trying to model it to some degree on a successful podcast we had 10 episodes ago with Joe Gibson, which was that we ended up using the shoulder and shoulder instability being central to Joe's expertise to then explore some of the oohs, ahs and nuances and complexities around the biopsychosocial model and application of a sensible holistic practice without throwing the baby out with the bathwater and dismissing some of the sensible biomedical and structural and biomechanical problems that then are around that. Now, if you think about then a condition-related proxy to that in the lower limb, then I just think the patellofemoral is such a perfect place to go there because there's, compared to, say, ACL and OA, etc., which of course have their complexity plenty, but it's just that there's some correlation there, I feel, between that conversation and this one. But then similarly, we think about the condition, but then who? And Claire has been navigating this conversation better than anyone, I feel, for many years now, and has a few different hats she's worn over time with regards to research, but primarily a clinician and educator simultaneously. That just feels like a perfect person for me to chat this through with. So thank you so much for joining me, Claire. I really appreciate it. For those that don't know some more detail on your story, if you could just introduce yourself for the listeners, that would be fantastic.
Sure. Well, first of all, thanks for the invite. I am a clinical physiotherapist. I work as a consultant physiotherapist in patellofemoral pain at Wimbledon Clinics, and I have worked in academia as well on and off for years, and therefore a researcher in, guess what? Yes, everything patellofemoral pain. And I run my education business, Claire Patella, which is the role is to help disseminate high quality education to both patients and clinicians. So a sort of triangle of teaching, clinical and research, but very much a clinician at heart, very much aware of the sort of needs, demands, difficulties of the clinician.
Yeah, no, that's brilliant, and certainly comes through in your work and your messaging, and even, I dare say, some of your frustrations, which we'll discuss as well when people get carried away on a theme. I think we're kindred spirits there. So one of the places that I felt it wise to start really is kind of the history, if we can, of patellofemoral pain, and then go into how that seems to correlate with some other body parts and conditions and trends, but where it deviates from others. So I just wanted to just get your reflections really on where we've come from, and whether or not you feel things have changed, and if so, in what direction.
Yeah, sure. Well, I mean, I think, if you reel back to some of the very early research, sort of say, go back to the 80s, people started understandably with anatomy, biomechanics, and to some extent, you can't argue with that sort of basic science, and that is a very valuable place to start. A lot of the early work was also cadaveric, which does definitely have its limitations. There was then a whole era of work around the VMO and EMG that went on and on and on, and really was quite inconclusive, but very, very biomedical. And look, that I'm not against that, and we need to make sure that we have an underpinning of science, and I'm actually a big believer, and I've taught anatomy, and a lot of my recent research has been with collaborative research with a clinical anatomist. So I'm not against that work at all. But it got such a head start that the body of literature is so immense around VMO, and then of course it moved up with an interest more proximally, and then of course some of the foot stuff came in, and so the body of literature is so immense around there, it gives the impression that that is the most important thing, which is not my belief. I believe it's really important, but it's not the most important thing. So then really so recently, I mean ridiculously recently, really, in the last, well, I published an editorial around beliefs and crepitus in 2010, and then I went on to do my qualitative work on that, and then we've had other great work, for example Ben Smith's work coming through, giving us much more of a rich understanding of the lived experience of patellofemoral pain. Mm-hmm. And actually some quite shocking and revealing findings around quite how devastating it can be to live with patellofemoral pain. Because on the one hand, you can kind of go, okay, I've looked at the sort of biomedical literature and it looks like it's this sort of, structural pressure problem. And then on the other hand, you've got now this new information saying people are changing their career aspirations because of it. Or, I had one of my patients in one of my interviews saying, this is a 26-year-old guy with a structurally normal knee, by the way, saying, I'm so perturbed by the noise in my knee, I think I'm going to only look at ground floor properties. I'm house hunting at the moment. Wow. So, these are really big things. And yet we have so little literature on this lived experience of patellofemoral pain. And I think when I teach, I often talk about the pain and movement reasoning model, which is essentially a triangle. And at the right-hand bottom bit of the triangle, you've got local factors, such as, that could be local to the knee, bone edema, it could be ischemia in the retinaculum, swelling in the fat pad, can't not mention the fat pad. Bottom left of the triangle is regional factors, so that could be our hip biomechanics, foot biomechanics. But then the top of the triangle in this model is CNS factors. So that could be a true sensitization, but it could be also beliefs, it could be anxiety, it could be depression, anything that might affect the perception of pain, the approach to their pain response, fear avoidance, catastrophization, kinesiophobia, any of these things. And, what the model says, and then the interesting thing is the model wasn't written for patellofemoral pain, but I just think it works so beautifully. In the model, they say, on a piece of graph paper, I can tell you I'm not doing it on graph paper. I just draw a triangle, and then it says, put a cross on the relative contributing factors. So, okay, we might have someone that's fallen over onto their knee last week and they're bruised around the patella. They're not catastrophizing. Fine. Okay, that cross might be in the bottom right-hand side, but really it's very, very rarely that. And if you've actually got a teenager who's on a sports scholarship and there's huge anxiety and she's got huge amounts of sporting load, but is anxious about reining back from that, or maybe we've got a young mum with patellofemoral pain who's got huge sleep deprivation, wants to get fit again, and suddenly doing a lot of kneeling with the new baby, those things are so relevant to how you manage that patient. We cannot possibly ignore it. And so I think to try and come in, and this is what I try and do, and look at everything from hardcore biomechanics and foot posture and femoral internal rotation, etc., but right through to beliefs, anxiety, depression, kinesiophobia. And and it doesn't need to be viewed as fluffy, because we can measure those things as well. We can use outcome scores, and I do in my clinical practice for those things. So I might use the hospital anxiety and depression scale or the Tampa score of kinesiophobia. There are ways of objectifying it as well, so that it might then seem a bit less fluffy.
Sure, yeah. If people feel that they want to put some numbers to it and have some data to bring to bear to justify some of their sort of decision making, or reflect that back sometimes to patients with regards to progress in that direction as well. That's a really good point, because I think people do have, you've alluded to then fluffiness, and I think that that's something that people do worry about. But then others, if we think about the journey from orthopedics, say structuralism, to then physios love nothing more that then it became the realm of biomechanics, that meant that then the people who like to play with Meccano in orthopedics left it alone for a little bit, or needed to, and so then we were busy trying to change said tracking or alter biomechanics to try and say normalize movement back then, particularly, and sort of a kinesiopathological model that we had of moving badly or well, which still, of course, we tap into, but it's not the primary. We then move towards, say, understanding tissue sensitivity better, both in terms of, say, its capacity and its local nociception, contributing factors from the fat pad, which you mentioned earlier. I'm sure we'll come back to a few times. But then also then the wider, sort of more central sensitivity factors. There is then a step that some take, not just to incorporate the macro biopsychosocial variables that are those anxieties, social pressures, stresses, the systemic inflammatory factors that can contribute to that, as well as then the psychological ones. But I guess that people then sometimes will go to a place where they then leave behind not just the history, but also some of those other local and regional factors in such a way that then it becomes, and off air I sort of caricatured it a little bit, didn't I, in saying that then someone presents with patellofemoral pain and they're given reassurance, a script for some mindfulness, and then suggest that if they go swimming at the right frequency, then all will be well. And I think that feels a very naive model, but also one where someone's possibly, let's give them the benefit of the doubt, especially because I made them up as being a clinician if they're doing that, is someone that's not doing it in an uncaring fashion. It's just that they've potentially bought into that it's so non-specific in such a way that then just getting someone moving sufficiently and to calm down their fret about it less, that's somehow going to be a really positive intervention. And I feel that I'll admit my bias in saying I think they've got carried away on a theme. I just wondered if you felt that is, do you recognise that? And also, how prevalent is it, if at all?
Definitely. And it's really interesting because pretty much my whole practice is second opinions. So it's very interesting seeing the journey that the patients have been on before. Right. And certainly, a lot of them get, and, perhaps this has also been exaggerated a bit because of COVID, because some of the advice has been, well, just don't worry about it, just get moving. And I think one of the problems with that is it can come across as very flippant. Right. And actually, it's really important that the patient feels that you're invested, and that, I have a strong belief that for that time, the patient's in front of me, that they really feel that they are the most important thing to me in that half an hour. that I'm listening, I'm thinking about them, I'm not distracted thinking about someone else just going to give a regular, the same old sheet out. And I think, and it was very interesting, this came up in my crepitus research. I remember it, and I quoted it in my final paper, actually. One patient said, I mentioned it to the GP, I mentioned it to the orthopedic surgeon, I mentioned it to the physio, and everyone said, oh, don't worry about that. And I remember her wording so clearly. She said to me, it might not matter to them, but it matters to me. And this is about listening to the patient's narrative. It's so important. So even if you take the view, I want to be really non-biomedical and really hands-off, okay, but you still have huge skill there in listening and devising something around their narrative. So to just be like, get moving, or, it is actually not even exhibiting skill around the psychosocial side of things.
No.
And I had a patient recently who was really quite distressed about the situation with the knee, and objectively, her knee really wasn't that bad, but she was very distressed. And when we explored it, actually, she said we worked out that she was missing going to the classes, her exercise classes. And then when we explored it further, was it the social interaction? What element was it? I helped facilitated, I hope, her realizing, as funny as it might sound, that she really missed the music in that class.
Right.
So first thing on her treatment plan was email the teacher, the instructor, get the playlist, and then do that at home, play that at home, which elevates your mood, makes you feel better, and then maybe we'll do your physio exercises to the music. And that's about digging for their, in, as I say, in their narrative. But it's effortful. And I also think there is something around the biomedical model sits very nicely with sort of hypothetico-deductive model of reasoning. So I've got my hypothesis, I'm going to deduce down, and then I'm going to give out this. And I think particularly for novice clinicians who have just qualified or recently qualified, who want to have a framework that works and they feel comfortable in, and they feel they can work through something, I think that is a nice place to be, a nice way to work, the hypothetical deductive, and it does often work really nicely. And even if you already have the diagnosis of patellofemoral pain, you might approach it, well, I'm going to hypothesize that they're different in different shoes, and I'm going to hypothesize down that maybe I deduce down maybe I need an orthotic, whatever. But if we go down the more psychosocial side of things, we have to work much more inductively to be effective. So it's okay, they're exhibiting distress, so can we work out what the distress? Okay, right, so we're talking about their exercise class. Oh, but actually now we're talking about the music. So what are we going to do? How can we evolve that into something meaningful for them as part of their treatment plan? And it's a more uncomfortable place to be if you're a novice clinician. If you're tight on time as a clinician, it's harder because you just want to get through. You don't want to, there can be this sense of, almost I haven't got time to explore. I'm very lucky. I have an hour with my patient. So that is a challenge as well. And I also think physios like to do. I think they like to feel, they like to move, they like to test. And not sit there and chat. And yeah, I like chatting. I like it a lot.
Me too, funnily enough.
Really. And actually, as I've got more experienced, I think I've got more confidence in just sitting and exploring the narrative and spending time on that and realizing how important it is. But not just doing that. And this is where it comes back to this sensible middle ground, that yes, I need to explore this patient that's distressed, or why are they so fearful about walking up and down the stairs, or why won't they kneel? What's going on here? But also saying, well, that's fine, but if they have pain in their knee, is there something physical that we can do, whether it's local to the knee, regional, whatever, that is going to impact on the knee, that's going to then feed into my attempts to decrease anxiety?
Yes, I think I feel that journey that sometimes clinicians are on they don't mean to be, but they can end up being dismissive. They're not being thoughtful enough of the specific factors affecting that person, and that all the evidence we have points towards it always taking less time than you'd think, right? It's not given the opportunity. A patient then rambles for an hour and you can't get the rest of your subjective assessment done and tick your boxes you need to tick to be vaguely competent, right? It's not that we've never seen work, as far as I'm aware at least, come out that suggests that you've got to be really careful and discerning with exactly what questions you ask or how much time you give them. Usually it surprises people when they then are told how long that did take and how much information you did get out there quickly. So I think people do need to just, find a way to make sure they elicit that narrative, because it's just, it can't be, there isn't a replacement for it. It's just not the sort of thing that they'd be able to find and feel through what we'd consider to be traditional, potentially, methods. And I do agree with what you mean about that. Inductive model is much more important, but I think that does seem to be the case, especially when there's been multiple clinicians that are behind it. I think as the physiotherapy game, but especially MSK practice more broadly, proliferates, then we're all going to be second opinion clinicians eventually. And most patients that we see in time are going to have seen, there aren't going to be many, especially of a certain age, that are going to have not seen a physio ever, aren't going to have some preconditions and understandings as to what that might be. And we need to think about that culturally. I wondered if we can just hover for a sec then on crepitus as an example of because it's such an interesting phenomena, and it's one that, the closest sort of proxy I can give to it elsewhere is with regards to the concerns people have about noisy spines, really. But generally, I know it is different in relevant ways, but it really can colour someone's sense of self. It sounds like it really is just them wearing out. Their perception of it being just, that can't be healthy because it sounds like a creaky door hinge, is such an interesting schema. So you've studied that to high heaven over the years, as well as then being a great communicator of that to us mere mortal layman's, really, in the physio game. What is it? How does it influence people? And how can we help see them past it without being dismissive, like you mentioned earlier?
Yeah, so well, in terms of what is it, it can be a number of things. So it can be, if it's sort of isolated pops, it can be bubbles of gas releasing. So, just like if you crack your knuckles. It can be a clunk, more of a clunk, which is often the patella sort of just clunking in the trochlea, and that's fine. It's not, an isolated patient, it's not dislocating, it's not coming out, it's okay, that's fine. But probably the one that elicits the most alarm is that sort of fine grating that you get on the stairs often.
Can we say they're like they're walking on crisp packets?
Yeah. And we can look to the engineering world to help us a little bit here. So there's a phenomenon called slipstick, which is the noise when fluid moves through a slightly uneven surface. So if we take the premise that it's normal to have some surface irregularity in your retropatellar cartilage, as the synovial fluid moves through that, it can make some noise. And the analogy I give the patients is, I say, look, if I pour water on a piece of sort of laminate flooring and swish it around, we might not get any noise because it's totally smooth. So maybe that would be like a sort of 14-year-old's knee. It's very easy to have some surface irregularity, and that's normal. It's not part of the arthritic pathway. It's totally normal finding. So I then say to them, imagine a deep pile carpet. So the deep, thick carpet's like your nice, thick cartilage reinforcement, but there's lots of cartilage there still. And I say, if I pour some water on that and swish it around, I'm going to get a friction sound. And, and I say to them, look, we have to separate the phenomena of pain and noise, because I try and have this conversation really on in their journey, because otherwise what can happen is you might have done a great job, it might be stronger, moving well, and the pain, say, gone, but they might still go out of your room and avoid the stairs because they feel on the stairs, oh, my knee makes this noise, and that's bad news, I'm damaging myself. So I have a question that I ask, and I find it incredibly helpful and incredibly revealing. So if they mention crepitus, I simply say to them, what do you think it means? And if they go, oh, I don't know, I don't think about it, right, fine, move on. But if they go, well, of course, it means my knee's wearing away, or, well, it means I've got arthritis, or I'm going to be like my mum who's got a knee replacement. Okay, stop. We have to spend time on that belief system because it's inaccurate and it's disabling to some extent. And that belief system ultimately will be more limiting than the pain itself, probably. So I I take time to explain what the noise is. And often I say to patients, look, the noise may have been there for a while, but when the pain comes in, you become hypervigilant. So you notice it more and your brain is sort of on red alert. So then every last bit of noise from your knee, you notice. My research also showed that sometimes family members kind of reinforce the alarm, if you like, about it. So sort of, oh, listen to those knees, or, oh, you want to get that checked out. So sometimes even if someone comes with a partner or whatever, just saying, look, it's really important that everyone just switches off to this and don't focus on it. Let's focus on sorting out the pain, your movement, your strength, what sports you want to go back to. And I place the expectation on session 1, just so I'm really hoping we can make a big change to your pain, big improvement to your function, but your noise may remain. So I'm placing that expectation there right from the start. Otherwise, they get to the end of their treatment, you might be really happy thinking you've done a really good job, and they might still think, oh, my knee's just not right at all.
Do you have any sort of either best guesses or informed by the literature as to what the reason is that people do sort of attend to it and worry about it? What is it about crepitus that makes people so concerned or anxious, or have
this
those
came out
perceptions?
this came out in my research, because my research was qualitative, emerging thematic analysis, so it gave me an opportunity to sort of dig around, and it seems to create this visual impression of bone on bone. Right. And people think, bone on bone arthritis. So the word arthritis came up again and again. And bearing in mind, my cohort was all non-arthritic people with a normal structural knee.
Sure.
So it's definitely, that's where it seems to lead people. So, and there's been further quantitative research since, both in the non-arthritic domain and the arthritic domain, both showing the crepitus has no correlation with odds of who progresses on to knee replacements. So there is no evidence that it's correlated with the arthritic pathway.
Does it correlate with anything else? Like, do we notice that a course of rehab and treatment, and it then can occasionally decrease in its noise? I know we wouldn't treat it directly, but as a side effect of our interventions, does it sometimes actually mitigate some of that?
Yeah, well, as far as I know, there's no literature on that, but anecdotally, sometimes it definitely changes. Sometimes it gets even louder.
Right.
Right.
Sure.
But I think it's because potentially you're subtly changing the mechanics. So the way that the fluid moves through that slightly uneven surface is subtly changed. And maybe the amount of movement of the patella is subtly changed, might become more if you've started off with a stiff patella, might become less if you've created more dynamic control around the joint. So I think, it does change sometimes. But, and again, I will often talk to the patients about that and say, look, it might change in how it sounds when it comes on. We're just not going to microanalyze what the sound is doing, because it's not helpful and it's not going to change how I treat you.
Gotcha. Yeah, absolutely. I've in my work in doing more second opinions than most, but no doubt far less than you, particularly around this region. But it's just it was mentioned briefly earlier, the fat pad comes up. I want to kind of get stuck into some of that and its influence, and also other tissues around there, as to what is it then that a good understanding of functional anatomy around the knee can it help us to, how would that colour our reasoning, and how should it colour our reasoning when people do present with patellofemoral pain, and namely, and the reason I mentioned the fat pad by name is because with just the relevant differences between what structure might be at least a primary involved.
Yeah, well, I think the fat pad really is quite a separate presentation. I think you can get them coexisting patellofemoral pain and fat pad and or patellar tendinopathy, but there are some distinct differences with the fat pad, the severity of the pain, the intensity of the pain, what tends to exacerbate it. So it's very much a pattern of extension, standing, walking, whereas patellofemoral pain is much more a pattern of flexion, stairs, sit to stand, that sort of thing. So we've got our fat pad, which can be chronically inflamed from a sort of micro trauma from poor mechanics. So for example, if you've got excessive femoral internal rotation, you might be just, the patella might just be tapping onto the superlateral fat pad, sort of a micro trauma leading to a macro problem. Or we might have actual trauma to the fat pad, like arthroscopy portals or a direct blow, something like that. So yeah, that's sort of one definite source of pain. We've then got sort of more curious sources of pain, perhaps in the patellofemoral joint, and I try and frame it generally around pressure. So I try and bring it away from the concept of damage, and I think this is incredibly important with patients in terms of their psyche. So I would never give out the term Chondromalacia Patella, but I end up talking about it a lot because patients often come with that term.
Yeah.
So often and again, it's one that's worth spending time unraveling, because the patients go, have got a bit of patellofemoral pain, they're sent off for a scan, are told, or even not that, sometimes they're just told, oh, you've got Chondromalacia Patella, and then of course they Google, and then it's, oh my God, my knee's falling apart. So actually, the best way to decrease alarm around that is to say, well, you know what, the nerve, the cartilage on the back of the kneecap that they're referring to, it doesn't have any nerve endings. So in the non-arthritic, I know it changes in advanced OA, but in the non-arthritic knee, that's not possible. It cannot create pain. And you can see them sitting there going, well, why does my knee hurt then? And so then what I do is I then explain, look, it's possible to have this fluffing up. And I say to them, look, if we'd scanned your knee before you'd had your pain, it would have shown that, it doesn't come overnight. But the pain comes from overload of the subchondral bone. So, and, even take our adolescent patellofemoral pain patients, they more often than not, have a pristine MRI. There's no cartilage damage, but you can still overload the subchondral bone through excess pressure. And we can get excess pressure when we've got poor distribution of load. And that might be intrinsic to them. So foot position, pelvic position, femoral position, anything like that. Or it might be extrinsic load creating just so much pressure. So sudden increase in training volume, or sudden kneeling a lot. So that's another classic. Or moved house, suddenly doing a lot more stairs, moved jobs, wearing high heels a lot. So the load, there's some sudden change in load, as I say, and the driver is sort of where it gets interesting. So that's where you put your detective hat on and work out, well, what's changed. And of course, often it's multifactorial, intrinsic and extrinsic potentially. But that's how I frame it, and that's genuinely how I think about it and how I approach it, is what is causing this excess pressure of subchondral bone. Now, if you reel on into the onset of the arthritic pathway, then you might well also see subchondral bone edema. But again, I say, look, it's a good news story, because the patient's coming, oh, doom and gloom, I've got arthritis. Right, well, do you know what? The source of your pain potentially is this subchondral bone edema. And do you know what? If we manage your knee well, we can decrease that. We can encourage it to go down. And, Michael Callaghan's done some great work on this with Q bracing, looking at nice, elegant study, MRI, wear the Q brace for as much as you reasonably can. I think the mean was something like 7.5 hours a day. Another MRI, I think it was 8 weeks later. And sure enough, I was seeing a reduction in lateral patellofemoral bone edema and a nice tight correlation with decreasing pain. So, we've got this sort of continuum in a way. We've got the adolescent population, then we've got non-arthritic adult patellofemoral pain, then we've got the moving into the arthritic population. Of course, with any of these, particularly as we move to the right of that spectrum, we might then start having synovitic pain, so an inflammatory response. And then of course that brings in all the really interesting research and literature around BMI and how important that is. Hugely important. So we've got so far we've talked about fat pad, we've talked about subchondral pressure, we've talked about subchondral bone edema, we've talked about synovitis, inflammatory pain. We've also got those patients that actually, I don't think the pain's coming from the joint, it's coming from the periarticular, parapatellar soft tissues, so the retinaculum. And sometimes they come in and they describe their pain, they get the hand and they sort of do a stripe down the medial border. And I think, often they're getting pain because that retinaculum is potentially chronically stretched. And I say to patients, look, I don't have a problem in my hand structurally, but if I do this and I do it all day, all week, my hand's going to really hurt. So we might have that scenario if we've got a lateralizing patella, medializing femur, where that the distance is greater. And of course, then you have on the opposite side, laterally, you might have some compression of the lateral retinaculum. And there is some work showing that we get a cellular change in these situations when you have long duration of symptoms. The retinaculum starts changing and we get some hyper innervation alongside some angiogenesis, a bit like in tendinopathy. So that's another potential source of pain as well. Just on that,
one of the things that I realised in the framing of my question is when I brought up the fat pad alongside it was more just that there is risk of misdiagnosis that can occur, and we see where it's just clearly not being considered or differentiated more carefully, and it feels like we're harking back to the days of anterior knee pain and those catch-alls, right? So I think and there's also certain masquerading variables, because you also get people then sometimes have been told it's fat pad, but fundamentally it's actually just a particularly sensitive, for whatever reason, say they've got a synovitis and some bony edema once we scan them, etc., that's made it more sensitive, that the therapist has sometimes just deduced that something this sensitive therefore must be fat paddy, because they can kind of rationalize that easier. So it's that differential really matters, because you would manage those things relevantly differently, because that's one of the things that often is feeding the logic, is that we didn't do further imaging or workup or be more specific because it wouldn't change the management. Let's do this somewhat more generic program, whereas the way in which we would manage those things is very different, and such that and also in such a way that sometimes that failure to differentiate can mean that it's ineffective. In these instances, it can be deleterious and really wind someone up. So that's kind of where the specificity you're bringing to bear, and us being a bit tissue-centric for a time, is really relevant for how it should colour your reasoning. And so I can really understand how and why you differentiate it. When things do, when it comes to the sharpening of what we feel are then, say, primary drivers, or whatever language we decide to use, what do you feel are good examples of how that would affect? What do we therefore suggest doing about it, right? What are some classic examples of how that would influence, say, rehab and other management?
Looking at sort of then reeling it back further to sort of causative factors. So obviously, you have the scenario at times where there is trauma involved, but even when there's trauma involved, you think, well, what then happens? Okay, they might have a bruised knee, but why are they still then having pain at 6 months, 9 months, a year? So, and it's interesting, if you look at the stats now, about 50% of people that have a non-fracture blow to the knee have pain at a year. So I think that group, for example, they often get that sudden onset of pain and or swelling, and I think that really does mess around with their quads, and I think they end up with quite significant quads atrophy, and that the post-surgical patients the same as well, like the ACLs, the post-meniscectomies that are doing fine potentially from that perspective, but they then get patellofemoral pain. I definitely think for those are my clues, sudden onset of pain and identifiable moments, if you like, almost where there's been a real change in their pain profile or their swelling profile. And I think we know that can really mess around with quads. So then we're looking at, potentially, yes, does this person need strength work? But I'm not going to, you can't go wrong getting strong thing, isn't there? And I'm not going to be saying to someone that's in the gym hugely strong with patellofemoral pain, you need to get strong, because and I do definitely see this a lot, that patients come through and I say, what have you had done so far? And lots of squats and lunges, and actually it made me really sore. I'm thinking, well, okay, so we might need to do strength work, but even if we do, it doesn't have to be squats and lunges. We can be a bit more sophisticated than that. So that's the sort of quad strength stuff. We've then got definitely patients that are tight, and I think the flexibility literature is a bit lacking, to be honest, but I absolutely still believe, patients that get more pain when they're sat, and then if you say to them, and then what happens when you cross your legs, they say, oh, it definitely makes it worse. Well, what are you changing there? You're changing the tension in the lateral soft tissues. So I think, and tight calves, definitely I'm a big fan of looking at particularly soleus length. If you've got a tight calf during your gait cycle, you're going to either excessively pronate to be able to dorsiflex, or you're going to have an early heel rise in your gait cycle. And there's been some lovely work showing people that have an early heel raise in their gait cycle are more likely to have retropatellar bone marrow edema. So we've got our patients with length issues. And also hip flexor length, people that sit, the classic weekend warrior, sits all week in an office job and then wants to go and perform at the weekend. So looking maybe at hip flexor length. So we've got our quads group, we've got our muscle length group. Foot posture, I'm always asking patients, do you notice a difference in different shoes, or if you're barefoot, in socks, shoes, trainers, flip-flops, and quite frankly, as simple as it sounds, if someone says no different whatsoever, are they really going to be a great candidate for an orthotic? I find that hard to believe.
Gotcha, right.
It's very basic, but it's I find that really quite a useful thing to ask. And then if they are different in different shoes, I think some of my patients think I'm obsessed about shoes because I'm always asking questions. But then I want to know, well, what shoes is it worse in? And if it's a high shoe, is it a thin heel? Or is it, or they might say, yeah, it's only a thin heel, I can tolerate being up there in a wedge. So, okay, then we've got an instability issue, potentially. It's not necessarily the height. So, or actually, is it that when they're in an office shoe and they're walking on pavement because they've got some bone marrow edema, they don't like the lack of cushioning. So actually, do they really need an orthotic, or do they just need a shock absorbing insert in their shoe? So really exploring around the foot thing. Then, we have got the whole concept of movement and movement control. And then it's question, I would be thinking, well, okay, I can see that when they jump and land, they, land really badly. But actually, they play netball and they're fine. And their pain is when they're sat. So how much is this relevant? Or actually, yeah, they've got their worst pain when they're landing from a jump on the netball court. I can see they're landing really badly. Let's try and see whether we can look at that. Now, it might have they got the adequate range, strength, and then are they aware what a good landing technique is? Can they do it from a neuromuscular point of view? Can they do it when they're distracted, fatigued, all those things? Okay, so I think that movement control for this person is important and I need to work on that. And then the huge area of extrinsic load. So, and have I seen this during the pandemic? My goodness, people who suddenly decide age 55, I think I'll run every day. And,
Sure.
I've got patellofemoral pain. So, or of course, all the home workouts and what have you. So looking at load, where's the load change come in, as I say, and again, even within that, there are sort of certain groups that I see regularly. So, the runner's load, the CrossFit brigade. Then then there's the sort of the young mums group often who end up with a lot of sort of squatting, kneeling, crouching, spending time on the floor. That kind of load, that's something I see regularly. Or it might be one-off load, like someone goes on holiday, although none of us have done that for a while, but go on holiday and they're, I don't know, sightseeing and up and down thousands of steps at temples and develop patellofemoral pain. So, there are definite things that I'm going to be looking at, all ultimately aimed at diffusing load at the patellofemoral joint.
Exactly. It all depends on the specifics that emerge from assessment that would then dictate as to where that goes. And that's where it becomes difficult for teasing that out in the data, because and why conditions such as this, or at least regions such as this, need to be multimodal sort of research methods because of the way in which it's not a classically homogenous group.
No, and people say all the time, "Oh God, don't you get bored of just doing patellofemoral pain?" I'm like, no, there's so much to look at, and it's so interesting, and there's so many different angles for sure. One of the things I just do want to make sure I just hone in on, because it's one of the things I'm not sure of your opinion on, is I've looked at lots of your work, but can be categorized as two schools of thought, and then there's plenty of room in the middle. But generally speaking, the idea of optimizing biomechanics around what was classically considered normal, or that there is an optimal window in which there would be then, classically defined as patella over second race, say onto a drop land, for example, and then a window around that. But then there's schools of thought emerging, particularly around, Greg Lehman, Ben Cormack's work, sort of suggesting that within a comprehensive capacity model, as long as that person is exposing themselves to those sorts of, say, valgus or varus stresses, especially if that's something that they have, for whatever reason, self-selected into it through having particular hip mobility or what have you, that it might not matter so much, and that window of exactly how they're moving there is less relevant. So I just wondered where you sit within that. Yeah, probably boringly in the middle, but let me explain that. So anyone that's heard me talk will laugh, will smile at this, but I bang on and on and on about my shopping basket of risk factors, because it's something that I really believe in. So take let's take someone that moves with a lot of femoral internal rotation, and take, you could look at an elite runner like Jeptu. She has won the London Marathon with a huge functional valgus. So am I going to change her running style? No, I'm definitely not. But so she's obviously able to absorb that. But it's back. So if we think about this concept of the shopping basket, if we have someone that is moving and dropping into internal rotation, they might well be able to absorb that. But if also in that shopping basket, they've got a shallow inclination to their lateral trochlear, then they are a ringer for lateral subluxation. So they might not be able to cope with those two features coming together. So in that person, I might say I need to just try and work on that internal rotation a bit, because they haven't the capacity to absorb that. So I'm looking at what's in their shopping basket and what can I alter. So, some things we can alter, so fine motor control potentially into internal rotation, but I can't alter their lateral trochlear. So that's going to remain in their shopping basket. So I need to make sure there's nothing in combination with that. Another example is some people have quite a lateralized tibial tuberosity, which gives a sort of like to use an old-fashioned term, a sort of Q angle. So they've got their quads coming down and the attachment is lateralized. So straight off, they have overload of their lateral patellofemoral joint. Now, loads of people have got that and are pain-free, getting away with it. But if then, they then perhaps spend a lot more time in, I don't know, a Converse one issue, and their foot dropping in and driving the limb into medial collapse, they might find that difficult to absorb because it exaggerates that load on that patellofemoral joint even more. But am I going to say to everyone, don't wear a Converse? No, of course I'm not going to say that. So it's back to this specificity, and I'm looking at these combinations saying, well, I can't change the trochlear shape. I can't change the fact they've got a patella ulcer. I can't change the fact they're hypermobile, but I can help them by, advise them about their shoe, or I'm going to try and re-educate so they don't jump and land into valgus. But for some patients, I'm less worried about it because, I might not think that it's that relevant to the picture. So it's back to the specifics, I'm afraid.
No, that's good. Just to poke on that a little bit then. So let's use that example where someone's in converse, lateralized tibial tuberosity, and the biomechanical variables that would contribute to it being reasonable to think that could be related to their pain. Let's say you did some symptom modifications in clinic and felt like that was a sensible sort of direction test in a way for you to then make some alterations. They then make some improvements through whatever intervention, be that proximal or distal, whatever it might be, or back it a number of different things that we combine for that. They're doing better. Is the logic that is a combination of things that is an inherent perfect storm to them? Or do you think that once they have resolved things, if they were to aspire to just manage their training load over time, that they could adapt to that cluster of biomechanical variables? Or do you think that actually describing what they are in that way, more likely that is a recipe for overload and recurrence? Like, I just wondered where you are.
Yeah, I think when we've got these structural features, like, as I say, the things that, immediately come to mind, I say patella ulcer, trochlear dysplasia, lateralized tuberosity, femoral neck anteversion. They're there. And, I think that they are vulnerable to recurrence. I do. And you see it, you hear it from the patients. Yeah, I've had this, my knee started hurting as a teenager. And every time I try and do a bit more sport or this or that, it rears its head. So, but that doesn't mean that they can't manage that with an awareness of it. And again, I sort of say to the patients, look, this is in the non-arthritic patients, there's no damage. We don't need to be worried about your knee, but we need to be smart about your knee. And I need to empower you to understand how to manage this really well. So it's okay to wear Converse, but don't wear them when you're going out shopping all day. Be a little bit strategic about it, say, in that situation. Or, I have another lady who has a very small hypermobile patella, and she often gets a bone edema, and she loves gardening. And I was like, look, I want you to be able to do all your gardening tasks, but don't do all the kneeling tasks in one go. So say, well, I need to do that down there, but I also need to prune this up here. So, do that, then go and have a cup of tea, then go back down to doing that. And and she's more than happy with that, because and I really want to give the patients that locus of control to understand it and manage it, so that they don't keep cycling back through with pain episodes.
I remember one of my mentors, Heather Watson, who an occupational health specialist and sort of functional rehab expert, but I remember she was advising for, let's say, district nurses and things like that with regards to kneeling strategies. But it was something that the penny dropped so much on that, where she's just like, what about on one knee for a bit? Just here's 5 different flavors of kneeling to explore in a typical working day, etc. And it was just that, honestly, even though I consider myself fairly creative with rehab then, I was either going to be talking about exposure and timing related strategy for it, or I was going to be looking for a temporary avoidance for it and trying to look at other. Whereas that middle ground is where the fun is, and actually thinking about different ways and mechanisms and even the angle of the hips, etc. So I think that's absolutely brilliant. Do you think the signal? So if we go back to that cluster of that pattern, do you think the signal is ever strong enough that if, hypothetically, you were doing world's most thorough medical on an otherwise asymptomatic 20-year-old, right? And it was just one of those things where you then happened upon, well, let's say it was, your own kids, for example, but would you then feel that the signal would be strong enough to sort of say, probably being an elite ice hockey goalie is not for you? Probably be, that you feel that the signal is predictive enough that you would then possibly a loved one away from doing a certain thing?
No, I wouldn't, because I just feel, I don't think there's enough evidence to do that. But what I would do, and it's interesting because I've seen quite a lot of elite tennis players with patella ulcer, so someone out there maybe can enlighten me whether there's a reason for that. But I say to them, look, your knee is structurally a bit tricky. You need to really understand it, and you really need to understand how you have to incorporate some of the self-management of your knee into your training so that it doesn't, periodically play up. Okay. So, no, I wouldn't steer someone away. I just don't think there's enough compelling literature to do that. I think that would be too extreme.
Yeah, it'd be really disruptive, wouldn't it? But you can understand that potentially in the future, that there is this cluster that starts to sharpen that signal. But it's interesting, and I would agree. I'm going to follow the bandwagon there and just nod along and agree with you, which is nice. But I think it's an interesting area of research that I always try and keep an eye on, because I think it is fascinating if we start to notice, say, more predictive rules, because what we do with symptomatic and asymptomatic, and how that affects it, sometimes if we don't tease those things apart, then that's how some fake news can really spread.
People, for sure.
So what you're saying is everyone should have an MOT and be put against a plumb line. It's like, well, no, very few people, if anyone high profile, is saying that. It's just that sometimes, as you've described it, there can be a combination of factors that can predispose, is what we're noticing, and that pattern is something that you might see in clinic easier than you might see in data.
Yeah, exactly. But saying that, there are so many different things that can potentially feed into patellofemoral pain, and of course we've been talking quite biomedically, ironically. Sure. But it's very difficult to find two people with exactly that same profile. Because yes, they might have the same foot posture thereabouts and lateralized tuberosity, but one of them might have more kinesiophobia than the next one, or so there are all those other psychosocial variables that come in as well. So it's about back to that basket. What's in there? What can we affect? But also framing it in a way that isn't alarming to the patients. Because if I just sort of said, oh, you've got a bit of a rubbish chocolate, right? Well, you've got that for life. You'd
be scarring them, them with that perception.
It's about educating, but not alarming in that situation.
Absolutely. Let's go a little bit more cerebral then. Let's go to sort of psychosocial factors or sensitivity related factors. I think where those two worlds meet is in the way in which beliefs can influence behaviours. We've touched on that a little with crepitus, and we've visited on many other podcasts, of course, about some of the detail over kinesiophobia, as well as then some of the nocibic influences and how that affects movement. But on this more specifically, and how it then can change biomechanics, I'll share a personal anecdote of which I've seen a version of plenty of times in clinic since, but long before I was a physio. I had problems with my knees growing up, this will make you wince, especially in your line of work, but they'd moved the football pitches round and not filled in the goalposts, right? So I'm running onto a pitch, I've put my leg down as a 12-year-old and I've hyperextended onto that on my left knee. We think it's, since learning, I think we took my PCL with it at the time, but mainly now I know sort of recurrent fat pad related issues, etc. But anyway, the way in which just my history of bothersome knees meant that when I got into, say, my version of snowboarding, so I do a lot of mountain boarding, I did later in life, I noticed that I had a really hip dominant landing strategy. And you kind of do that on a snowboard anyway to stop you going up onto your toe edge. But on a mountain board, you've got a bit more play. But I was noticing, compared to my peers, I just wasn't trusting my knee into landing. And that carried with me for a long time. And as I say, I've seen, that's quite a niche sports and niche story, but there's a lot of versions of that whereby people, be a combination of pain, crepitus or otherwise, or just a sense of vulnerability of their knees, means that they then change the upstream biomechanics on, say, hips, back, etc., on, say, landing mechanics, etc. What do you think? Is that something that old habits die hard, and therefore sometimes you've got to be careful what you do if you unpick that? Like if you start to distribute those forces more normally, then that might not be normal for them, and you could unearth things. Historically, people be worried that then, you might improve their knees but worsen their back. I just wonder what your thoughts were.
Yeah, I mean, there's definitely a case of that at times, and it's like taking runners over to forefoot running. It's it can just, their knee might feel better, but they might end up with a calf problem. Or there was a while where people were taking people into more trunk forwards lean to help knee pain, but then it gives them back pain. So
the hammies as well.
So we need to absolutely be aware of that. But also, when we're changing movement, we don't need to be necessarily purist about it. Sometimes I think that the change can be quite subtle to get what you want. So going back to that sort of concept of functional valgus, someone dropping in, it doesn't necessarily mean that I want them to have their knee over their second toe all of a sudden when it's been 30 degrees internal rotation. It might be that 5 degrees change in that is enough just to make the difference. And of course, and if we are changing people's movement patterns, we have to do it gradually. But I think you have to do it gradually anyway to get the neurological new pathways there, so that they're not able to think about it the whole time.
So purely as a means of interview style, I often do present things as far more binary than they are. But some of the loudest voices in the space are, when it comes to interventions, shall we say, or adjuncts, there are people that can be completely nihilistic, and then there's people that are, that's the majority of their care. You couldn't call them adjuncts really. Within a half an hour session as a follow-up, then the vast majority of it is interventional, say that through manual therapy, tape. I've always saw, those noisy voices aren't necessarily representative of the evidence, but also I feel that you've navigated that space in a really interesting way with regards to judicious use of tape. You also either invented or at least promoted the ICE way as a device of means just of bedding that, having a more convenient way of which you can ice the knee. What's your thoughts on what interventions you feel are at least up for judicious use, and which have which are definitely not on the menu regardless of circumstance?
Yeah, so I mean, ultimately, the bottom line is if we can do something, whatever it is, and I'll talk about whatever it is in a minute, but if we can do something to the knee locally, and it decreases pain, increases confidence, increases their confidence in you, increases in their engagement with their treatment, increases their listening to your education, then they're worth doing. And this is where, I think it just facilitates other things. So tape, I do use tape quite a lot. I find it really helpful to alter the pain response, to give me a window to do, as I say, those things, more effective exercises that they'll do well because they're not in pain. They'll be more inclined to do them, more confident with their movement, hopefully. So I think tape is incredibly useful, but I'm a total pragmatist. I go for the most simple techniques that I can do, because ultimately most of us don't have the luxury of our patients coming back, every day or two. So there's no point, and it's amazing how many patients say, oh yeah, my physio taped me up and it felt great. And then I say, do you want to show me? Oh no, I couldn't do it. Like, well, what's the point of that?
But I think one of the things as well is that now, if you couple it with a mature attitude to then, that can be an incredibly reassuring intervention. If it's then saying it's only a bit of tape, and you clearly can't be that broken, right? Especially when someone's felt that there is a sense of structural or biomechanical fragility that's leaving them super vulnerable. Then it's when someone, historically it'd be like, well, my special hands and special tape have meant that this is corrective or curative, means that is not going to actually improve their sense of vulnerability. But actually then, as long as we can be humble enough to say, if it's just a bit of tape that can do that, then that gives us, we can be quite optimistic about the potential, but it takes for that humility and maturity of a clinician to then, not own that win too much.
Exactly. Not go,
don't get me wrong.
No, you're absolutely right. I think that, look at my marvelous taping that I've done to you as the passive recipient. I absolutely agree. And it's like, and I will often get the patients to tape it themselves in front of me, and I'll video them on their phone and make sure that they can replicate it. So definitely tape. ICE I really use ICE with the fat pad, and I know that ICE had a lot of bad press recently, but we need to be clear about why we're using it. So we know that fat pad problems are associated with perfusion problems. That has been shown in very recent literature. So if we've got excess perfusion through vasodilation, it's not a structural healing scenario that I'm looking at. It's an incorrect vasodilation scenario. Right. So the ice is really effective at causing vasoconstriction, reducing the perfusion through the fat pad, therefore it reduces in volume, and then you help to break the cycle of it impinging because it's too big. So I do find the ice massage really helpful for the fat pad patients particularly.
Would you say then that something like a pressure device, like a Game Ready or equivalent, would you could make sense of that with regards to the pressure, the entire area being cold? The ice massage, whilst no doubt, and use it myself as being something that is, would that apply enough of the, say, pressure related variables, or get the area cold enough to have the effect that you're describing? Or would it be that then...
my experience, and it is anecdotal, is that it gets colder with the ice massage. Right. And I get them to apply a bit of pressure to the fat pad as they're doing it.
Right. Okay.
I mean, it would be really interesting to look at, as you say, something like Game Ready versus ice massage to see, what the effect was. But certainly,
Game Ready, if you're listening, let's get on it. No problem. Yeah, but you're right. It would be. There's lots of different devices making all sorts of different promises of far more expensive than ice massage.
Exactly.
So we want to understand what that is for sure.
Yeah.
But I just think that's definitely interesting and a sensible application of it. And you're right, the literature's in an interesting place with that, and there's lots of people with strong opinions. I didn't want to cut you off with regards to you going through.
No, it's fine. So patella mobs. So this is an interesting one, isn't it? I do patella mobs. And but there are certain patient groups that I would particularly be looking at. So some of the post-surgical patellofemoral pain, I think they've had an effusion, maybe the whole area just feels sticky and gummed up, and I think that they respond really well to patella mobs. But again, I laugh at the patients. I say, right, we're going to do some kneecap wiggles, and I say, oh, that's really scientific, isn't it? And then I say, let me teach you how you can do the wiggles as well. And then I think that can relieve pressure and load, because you're getting the patella moving as it should do. But I'm not doing patella moves on everybody, and I'm certainly not thinking I'm stretching out the lateral retinaculum or anything like that. I'm doing it to try and physically move it in a situation where, for whatever reason, and it's normally OA or when there's been a lot of swelling, when there's been an effusion, when I feel that the patella is stiff. Mm-hmm. So again, it's patient selection, isn't it? So I'll be doing that. Just thinking about other, and then I guess other sort of moving up a little bit. This is going to cause a sharp inhalation of breath from some people, but I do use foam rolling. Right. Not on everybody. And I've just had it accepted for publication. Actually, we've done a trial looking at foam rolling on the muscle architecture of the Vastus lateralis. And what we found was that people who have a big angle, so they will be your hypertrophy people. So think like cyclists, big VL. If they foam rolled every day for 6 weeks, that the angle of pronation was less on ultrasound at the end. And we also did the same study where we replicated it with stretching, and we found the same result. So if we take that back to our intuition as a clinician, that patient that comes in with big, tense BLs, as I say, as a think cyclist, they actually may be a good candidate for foam rolling or stretching or both. But I'm not giving that out to everybody by any means.
But then also, and that's what's interesting, isn't it? Because in your next breath, you're always discussing mechanism, just as I'm about to ask what you think you're doing with it. But it's like the classic is that people would often torture themselves on foam rollers more laterally onto their RTB and TFL as a means of then saying that this structure is tight and it needs work in order to stop pulling you laterally and pulling your patella laterally. So it's that you're simultaneously needing to make sure you clarify that age-old style is not what's being pursued here. That mechanism is not what's
so
being
we were foam rolling the Vastus lateralis, and in fact, interestingly, I think when people roll on their side and they think they're rolling the ITB, I think they're catching the VL, and because the ITB is non-contractile, so I really can't see how that's going to be a useful thing to do. But if you're affecting a contractile structure and you're affecting the tone, then as we've seen and shown with ultrasound, you will affect the angle of pronation, which ultimately can potentially alter the patellofemoral kinematic.
Because that's interesting. I've not heard that and I need to read that, but I certainly know the massage literature a little better in more recent times, working with Matt Scarsbrook, Anna Maria Mazzieri and Becky Horton and colleagues that have got an interest in making sure that they debunk without being clumsy. And they've obviously shared with me a lot of work about influence on tone, etc. That's been then uncoupled sometimes from just people saying, well, that person's just more relaxed. It's like, well, no, there seems to be more lasting effects there. But while still being confident in debunking the breaking down scar tissue and altering adhesions and stretching things out and the retinaculum. So which especially that in their world, they're just sort of sick of the torturing that goes on under sports massage and foam rolling. So it is that mechanism and then what he's explained to the patients, as well as how that influences your reasoning. It means that we need to make sure we don't lump those in together, but also it sounds like maybe not be dismissive of it as well. So perhaps I don't, and perhaps I need to bring a foam roller back into my quiver of gadgets then potentially. What about sharp tools? What about dry needles or injectables?
I don't personally, but I think that there is a place for it, definitely. With, again, if you're thinking of particularly perhaps calf and VL are the two that really spring to mind, and TFL, and it's really tense, high tone. I think that patients do respond really well to dry needling, so I'm definitely not against that, but I wouldn't be doing that in isolation. I think that's the other thing, is that I'm not just taping or just rolling. I would never do that. It's alongside education, and it's alongside empowering the patient, and it's alongside looking at their extrinsic load and what shoes are they wearing and do they need some strength work. It's part of a package. But also on the other end of the spectrum with that is making sure we don't overload the patient. And that's another interesting thing running a second opinion service. I say to patients, it's very interesting. I say to patients, what were you given by the physio? And they often will say exercises. So I say, fine. And I have a question that's quite interesting. I say, what was the gist of the exercises? And I'm not expecting them to sort of say, inner range gluteus medius, or, I'm expecting them to sort of say, get stronger here at the side of my pelvis, or stretch the front of my thigh. I'm looking for something like that. And often they just can't say. They just sort of say, well, exercises to get better. So there's no understanding or buy-in.
Right.
And then I say, okay, well, should we have a look at those exercises? Pull out like a scroll. And I'm like, oh my goodness. So you were being asked to do these 20 exercises 3 times a day. So that's another interesting one as well. So where is the buy-in? Where is the selectivity, the clinical reasoning? Where is the exercise physiology underpinning of the exercise dosage? And alongside this, have we had any education? So, look, I'm not seeing that all the time. And I certainly don't want to slate my own profession. And you certainly wouldn't want me treating your shoulder or neck or something. But I think there are some really useful lessons to be learned there. If you give out exercises, it's quite an ask. Everyone's busy, whether it's work or kids or whatever. It's a big ask to ask people to repeatedly do exercises. And I thought Ben Smith's, I'm sort of going all over the place at the moment, but I thought Ben Smith's work was fascinating on this. So his emerging thematic analysis showed very clearly that patients believed that their problem had often been caused by exercise, which of course it is, in the sense that that's the onset they started running or started CrossFit or whatever.
Yeah.
And then they therefore felt that a treatment that was housed around exercise was not only not going to help, but was potentially going to be harmful. So if your patient comes in and you haven't actually explored, explained, educated why they need to do these exercises, they're going to go away potentially, if we're trying to be evidence-based about it, saying to themselves, well, why am I doing exercises when actually this is what caused my pain in the first place? And actually, when I do these exercises, it hurts. I'm not going to do those. And in fact, in my crepitus research, I said to the patients, one of the questions I said was, if you were given an exercise and it made your knee make its noise, what would you do? Every single patient said, oh, wouldn't do it. I was like, we have to know this. This is so important because exercise is central to the treatment of this condition. And yet I've got evidence here that these patients in my trial are consistently, every single one of them saying they're not going to do it if it makes their knee make their noise.
Yeah.
So then we cycle into the interesting thing around pain and exercise. Should we be exercising into pain? And I know this one often, again, people have quite extreme views on. Yes. And again, sorry about this, but I end up sitting in that boring middle space again. But I'm very careful how I present this and frame it to patients. So my belief is that if you give out patients exercises that are really painful, not only might it mess around with their dynamic firing, we know that pain does that, it's not pleasant. And they might, so who wants to do painful exercises? And are they really going to do them? And are they going to have confidence in you? And are they going to come back? But am I going to wait until exercises are pain-free? No. So what I tend to say to patients is, look, when you're doing this exercise, let's have some rules around it. Let's say it's okay to go up to 3 or 4 out of 10 and be a bit sore for up to an hour afterwards. And I explain them because then that's just a pressure reaction. It's not an inflammatory reaction. If it's sore into the next day, we've set off an inflammatory response. So I explain it. And then I say to them, and I think this is so important. I say to them, I'm not worried that we will be doing anything harmful to your knee, even if it is sore. But I don't think it's helpful or nice to be doing painful exercises. But I'm not worried about harm. And I'm really careful to clarify that because I don't want them to go away thinking, oh, I need to be careful it's not too sore when I do this, otherwise I've really harmed my knee.
Yeah, absolutely. No, that's the sweet spot. Thank you so much for your time today, Claire. Really appreciate it. Thank you for your contributions over the years too, especially to Therapy Live. This is Knee Month for Physio Matters, and so we've got bundles and packages there. Claire's kindly contributed to much of that, which is brilliant. But tell people a little bit about where they can find out more about you, your course, etc.
Yeah, thank you. Well, it's really that is my website. So www.claire, so that's CLAIRE Patella.com, clairepatella.com, and there's all my publications are on there with links through to those. There's lots of stuff for patients. There's lots of clinical reasoning, case studies, and then details about my courses too.
Fantastic. Where would they find you on social media?
So it's Claire Patella for Twitter and Facebook, Instagram as well. But most of the stuff I post is on Twitter. Yeah.
Oh, fantastic. Thanks so much again for your time and for being such a voice of reason in this space. It's absolutely brilliant and exactly what we need to all aspire to. And having regional body part specialists such as yourself, as well as applying the sort of macro and understanding how it attaches to those more complex humans up the chain is really valuable. So really thank you for all your work.
It's a pleasure. It's a lot easy to talk about this topic.
Yeah, nice one. Take care.
Thank you.
Brilliant. I think you will all agree with me that was absolutely excellent. Way more applicable information than just to the patella from Claire. Loads to think about. What are we doing with different interventions? How are we applying them to individuals? How are we creating our treatment programs and paradigms based upon an individual person, but still being evidence-based? Loads and loads of information in there as well about communication and how we might go around assessments and treatments. Just so much. In fact, I think I might go back and have another listen to this podcast again. So really hope you enjoyed it. Once again, just want to point you towards physio-matters.com, where you can get the knee bundle from this month. We've got other bundles there as well, or you can become a premium member. Don't forget to like and subscribe on whatever channel you're watching on. And believe me, if you're not subscribed on YouTube or on a podcast channel, you're going to want to be for April onwards. I mean, immediately onwards. Fill your time by going back and listening to the previous 97 episodes plus. But, you know, whatever. Get on board now. We've still got tons of information to bring you, loads of gold content, and we can't wait for it. So the final thing left for us to do is for Claire to give us the cheesy sign out. But we will see you next time on the Physio Matters podcast. Bye for now.
You've been listening to the Physio Matters podcast, discussing physio matters because physio matters.
Brilliant. Thank you very much.